CCRN Endocrine Practice Questions and Answers with Explanations. 25 Most Asked Questions. Question 1. A patient with SIADH is likely to exhibit which of the following laboratory findings? Serum sodium 125 milliequivalent/L, urine osmolality 600 mmosm/kg. Serum sodium 150 milliequivalent/L, urine osmolality 100 mmosm/kg. Serum potassium 5.5 milliequivalent/L, urine osmolality 300 mmosm/kg. Serum glucose 400 mg/dl, urine osmolality 800 mmosm/kg. SIADH involves excessive ADH, causing water retention and dilutional hyponatremia. Urine is concentrated, high osmolality, while serum is dilute, low sodium. Question 2. Which of the following is a hallmark clinical finding of diabetes insipidus? D. Low urine output, high urine-specific gravity, polyuria with dilute urine, weight gain and edema. D is characterized by a deficiency of ADH or resistance to it, leading to the excretion of large volumes of dilute urine, specific gravity 1.005. Question 3. A patient in DKA has a blood glucose of 450 mg/dl and a pH of 7.20. What is the priority treatment? Bicarbonate bolus, isotonic fluid resuscitation, subcutaneous long-acting insulin, D5W infusion. The priority in DKA is volume resuscitation with isotonic fluids, normal saline, to restore perfusion and address dehydration before or concurrent with insulin therapy. Question 4. In hyperosmolar hyperglycemic state, HHS, why is ketosis usually absent? The patient has no insulin at all. There is enough insulin to prevent lipolysis. The glucose is too high for ketones to form. HHS only occurs in type 1 diabetics. In HHS, typically type 2, there is sufficient endogenous insulin to prevent the breakdown of fats into ketones, but not enough to control hyperglycemia. Question 5. A patient with primary adrenal insufficiency, Addison's, is at risk for which electrolyte imbalance? Hypernatremia and hypokalemia, hyponatremia and hyperkalemia, hypercalcemia and hypomagnesemia, hypokalemia and hypocalcemia. Lack of aldosterone leads to sodium wasting, hyponatremia, and potassium retention, hyperkalemia. Question 6. What is the primary goal of treating thyroid storm? Increasing metabolic rate, reducing serum T3 and T4 levels and blocking systemic effects, administering 4-levothyroxine, inducing shivering to cool the patient. Thyroid storm is a hypermetabolic crisis. Treatment focuses on blocking hormone synthesis, PTU/methimazole, blocking release, iodine, and blocking peripheral effects, beta blockers. Question 7. A patient's urine-specific gravity is 1.002. This most likely indicates SIADH, diabetes insipidus, prerenal OCI, adrenal crisis. Specific gravity below 1.005 is a classic indicator of dilute urine seen in D. Question 8. Which fluid is most appropriate for a patient with a serum sodium of 160 milliequivalent/L due to D? 3% normal saline, 0.9% normal saline, 0.45% normal saline, lactate ringers. Hypotonic fluids like 0.45% NS are used to correct free water deficits and lower serum sodium in D. Question 9. A patient in myxedema coma should be monitored for which life-threatening complication? Tachycardia, hypertension, hypoventilation and respiratory failure, hyperthermia. Myxedema coma involves severe hypothyroidism leading to profound CNS depression, hypoventilation, bradycardia, and hypothermia. Question 10. Which medication is typically given first in the treatment of hyperkalemia with ECG changes? Insulin and dextrose, K-oxalate, calcium gluconate, albuterol. Calcium gluconate, or chloride, stabilizes the myocardial cell membrane to prevent lethal arrhythmias, though it does not lower potassium levels itself. Question 11. What is the expected laboratory finding in a patient with primary hyperparathyroidism, hypocalcemia, hypercalcemia, hyperphosphatemia, hypomagnesemia? Excess PTH causes increased bone resorption and renal reabsorption of calcium, leading to hypercalcemia. Question 12. A patient with DKA has a potassium level of 3.2 milliequivalent/L. What is the nurse's priority action? Start the insulin infusion immediately. Hold insulin and notify the provider to replace potassium. Administer a potassium-wasting diuretic. Administer 4-bicarbonate. Insulin shifts potassium into cells. If the patient is already hypokalemic, starting insulin can drop potassium to dangerous levels. Replacement must begin first. Question 13. Which endocrine disorder is associated with a moon face and buffalo hump? Addison's disease, Cushing's syndrome, pheochromocytoma, Graves' disease. Hypercortisolism, Cushing's, leads to abnormal fat distribution, including supraclavicular fat pads and facial rounding. Question 14. Pheochromocytoma is a tumor that causes excessive secretion of cortisol, catecholamines, ADH, thyroid hormone. Pheochromocytoma arises from the adrenal medulla and secretes epinephrine and norepinephrine, causing severe hypertension. Question 15. Which test is used to diagnose diabetes insipidus? Water deprivation test, dexamethasone suppression test, oral glucose tolerance test, ACTH stimulation test. The water deprivation test assesses the kidney's ability to concentrate urine when fluids are withheld. Question 16. In SIADH, the fluid restriction is typically limited to 500-1000 ml/day, 2000 to 3000 ml/day. No restriction. Only 4 fluids allowed. Restricting free water is the primary treatment for mild to moderate SIADH to increase serum sodium levels naturally. Question 17. A patient with HHS has a blood glucose of 950 mg/dl. Which acid-base balance is most likely? Metabolic acidosis, metabolic alkalosis, normal pH, respiratory acidosis. HHS generally presents with a normal or near normal pH because ketosis is absent. Question 18. What is the mechanism of action of desmopressin, DAP, in central D? It blocks the action of ADH. It acts as a synthetic replacement for ADH. It stimulates the adrenal cortex. It increases insulin sensitivity. DAP provides the ADH that the posterior pituitary is failing to secrete. Question 19. Which of the following is a symptom of hypoglycemia in a critical care patient? Dry, flushed skin, diaphoresis and tremors, bradycardia, polyuria. Hypoglycemia triggers the sympathetic nervous system, leading to sweating, shaking, and tachycardia. Question 20. A patient with an adrenal crisis, Addisonian crisis, requires immediate administration of glucagon, hydrocortisone, spironolactone, furosemide. Glucocorticoid replacement is vital to reverse the life-threatening effects of acute adrenal insufficiency.